Good evening, everyone. This is the 18th edition of our Ocular Genetics Interest Club. I'll just take a second to introduce myself first. I don't think I've introduced myself officially here. My name is Nivedita. I'm a new genetic counselor in the Ocular Genetics department at Shroff, and I'm happy to meet you all today. So today we have two interesting presentations by Dr. Monica and Dr. Neelam. First presentation will be by Dr. Monica. She's a senior consultant of Pediatric, Squint and Neuro Ophthalmologist in Laxmi Eye Hospital, Mumbai. She's also academic in charge at Laxmi College of Optometry. She's addressed several conferences and has an award-winning poster at the American Academy of Ophthalmology. She also has many publications. To her credit, she's done her fellowship training in general ophthalmology at LEI, and she's also trained at LV Prasad in Hyderabad in pediatric squint and neuro ophthalmology. Welcome, Dr. Monica. Next speaker will be Dr. Neelam. She's senior consultant pediatric ophthalmology and strabismus at Aravind Eye Hospital in Tamil Nadu. She's pursuing her PhD at the University of Maastricht, Netherlands, and her thesis topic is artificial intelligence in myopia in pediatric and adolescents. She's an ex-researcher, scholar at University of Michigan. She's an editor at PLOS1 Journal and a reviewer at Ophthalmic Genetics, Journal of Glaucoma and Clinical Ophthalmology. She also has many articles to her credit. Welcome, Dr. Neelam. We'll start with Dr. Monica's presentation. She will be talking about a tale of the wandering lens.
Hello, everyone. So I'm still new to the genetic world, but it's an attempt, and please bear with me if you find any mistakes, and please correct me on that. So starting with the case, the wandering lens. Next. Can I shift it?
Yeah, sorry.
So it's a 2-year-old young child was brought by his parents for holding objects very close to his eyes. Birth history, developmental history was normal. Next. When we saw him, his best corrected visual acuity follows light. What his anterior segment shows was megalocornea, both eyes. Iridodonesis, phacodonesis was seen. And in undilated, the pupil was completely phakic. Next. So March 2017, an under anesthesia examination was done. The cornea was 16 millimeters. Anterior segment, next. Anterior segment, the lens seen in the pupillary area in the right eye, and left eye showed a small subluxation. Retinoscopy was minus 22 diopters, and the pressures were normal, 12 and 16. Next. So the management was patient was prescribed glasses, child was referred to a pediatrician to rule out systemic illness, and the patient was called for follow-up after 3 months. The pediatrician examination, he had age appropriate development. He was negative for any syndrome. The 2D echo color Doppler was normal and metabolically also normal. So his homocysteine was negative because we were thinking in terms of ectopia lentis. Next. So we diagnosed him as both eyes megalocornea with ectopia lentis. Next. So ectopia lentis, as we know, is if the trauma is negative, we can divide it into simple ectopia lentis, where the genetic is either autosomal recessive or dominant, usually presents in 20 to 65 years, and superiotemporal displacements are seen. Ectopia lentis et pupillae is congenital with autosomal recessive. Pupils are usually eccentric and ectopic, and evident iris atrophy is seen. Ectopia lentis associated with systemic associations, we have Marfan's, Velmechensi, and many other of them. So in our 2-year-old with subluxation with megalocornea and high myopia, there was a small inferior nasal displacement in the left eye, and systemic investigations revealed everything was normal, physically and metabolically. Next. So as we go through these visits, he visited in 2017, and as you go down to by October 2017, in the left eye, he was aphakic. So the lens got dislocated in the vitreous. By the time he was 4 years, that is September 2018, if you see last this column row, he was left aphakic in both the eyes. We told him to have a genetic testing done at that point in time, but he was not, they were not so keen on it. Next. Next.
1 second. Yeah.
Yeah, so these are the slit lamp images where you can see that he has got distinctly a large cornea, megalocornea. If you see near the pupillary margin, you can see this whitish membrane which is seen over there. I won't say a membrane, but a line which is there, which is seen, which probably would be a remnant of the persistent pupillary membrane. That's what I thought in retrospect after reading literature. So probably that is what it looks like. And he's aphakic in both the eyes now. Next. This is how his lenses were fallen in the vitreous, both of them. And he was not symptomatic for anything. Pressures were normal at this stage. Next. So we advised him bifocal glasses. We gave him patching in the left hand, told him to follow up after 6 months. Next. So visit in 2024, that's like 10 years. And best corrected visual acuity is 6.9 in both eyes with a correction of plus 2.5 with a near add of plus 3. His anterior segment had megalocornea and aphakia, and the posterior segment was myopic fundus, but there was no lattice or anything in it. Next. So if you see the timeline, he presented to us at 2 years of age. Next. And he had his first lens drop. He was minus 20 at that point. At 4 years of age, he was having plus 7 and plus 8. Both the lenses had dropped, and we followed him up throughout. So almost 7 years of follow-up, and the child was maintaining very well. Next. So what we had done was we had chosen not to remove the lenses and manage conservatively with spectacles and regular follow-ups. Next. So clinical literature review, actually at that point in time, what I had done, found that all these children who had microspherospacias, most likely that's what we thought he had, ectopia lentis, were either anterior dislocations and usually had something metabolically, either they had positive or they had trauma, which had led to anterior dislocation of the lenses, which were removed. Posterior dislocation of the lens with such a long follow-up was something which we did not come across in the clinical literature. Next. So the unique case and challenging facts about the case was it was a bilateral spontaneous dislocation of the lens in the posterior segment. No other ocular association apart from megalocornea. No history of any systemic illness. Following up those child for 8 years since the dislocation in the vitreous. And there were no adverse events. And he had excellent visual acuity. We did not do an invasive attempt to remove the lenses because there was like complications of glaucoma and retinal detachment were there reported in literature. So we just left because everything was fine. Next. So no intervention actually we thought was best, and we wanted him to do the genetic testing just to know what we are looking at and to have a confirmation of the diagnosis with him. Next. So in 2024 November, the parents agreed and we had a genetic testing done. And this is what the genetic report showed. So the gene was LTBP2 gene, where the location was on exon 5. And we had a variant with zygosity homozygous, and the disease told that it was microspherophakia and or megalocornea with ectopia lentis and with or without secondary glaucoma. Inheritance was autosomal recessive, and classification was it was likely pathogenic. Next. What the variant interpretation and clinical correlation stated that a homozygous one base paired deletion in exon 5. What I wanted to say here was the variant was not been reported till now in the 1000 genome. And please check me on this if I'm making any mistake. Genome add. Next. Yeah. So that made me search in the literature and came across a study which was on compound heterozygous mutation in LTBP2 gene, which was associated with microspherophakia. It was a case report with a literature review of LTBP2. And this was presented in 2021. So what they said was that so far there have been very few reports of microspherophakia as a pathogenic genes, and LTBP2 is the only known causative gene for microspherophakia. And it's located on the long arm, the chromosome 14, and contains 35 exons. What did Najad et al. Actually say that this gene helps LTPP2 expression levels in the trabecular meshwork, ciliary process, Desmond membrane, and lens capsule were the maximum. Next. And so it was essential for the development of the serially zonular microfibrils that are required for assembling elastic fibers and suspending lenses. So deficiency causes lens luxation due to ciliary zonule fragmentation. And the ocular diseases associated with this gene were Well-Mackenzie syndrome, only microspherospacia, megalocornea, and ectopia lentis. Next. So this was a literature research that I tried to do, and what all studies have been done and what have been published till now. So 2009 was the first time that it was published. And in that, they had shown that multiple axons were involved and the patients had primary congenital glaucoma with megalocornea. So most of these studies had homozygosity, except for the study which is of 2021. If we go from chronologically 1, 2, 3, 4, 5, 6, 7th study, third last from 3, which had heterozygous zygosity. And the last study, which is Verma et al. 2025, which was the latest one, which is the largest one, which talked about 189 patients with this gene and mutations and showing glaucoma in all the cases. Next. So studying all of that, I try to make a table of what is the phenotype spectrum that you get when this particular gene is affected. So one thing which stood out the most was that megalocornea was common, and it was most likely because it affects the extracellular matrix and causes weakness and stiffness of the cornea, which increases in size. Ectopia lentis was also almost most of them had. And microspherophakia, though it was there, it was not present in all the cases except for Kumar et al. And who said that exon 36 mutation, if it was there, the patients exclusively had only microspherophakia. Childhood and secondary glaucoma were also common, and high myopia was variable. So our case had megalocornea, had ectopia lentis, and had high myopia. Glaucoma has still not set in and has not come. Next. So 7 years since the fall, recently in March 2025, this child presented now with, next, a small the lens coming into the anterior chamber of one of the eyes. Next. So then next. So we extracted the lens. Next. And the child is still now 6'9" and 6. Pressures are still maintained. His disc is still normal, has myopia. One eye does not have a lens. The other eye, now in the true sense, actually, is not truly is aphakic, but has the lens in the vitreous, left eye. Next. So what genetic did was help us confirm the disorder, and we could know what to look for in the future. Next. Yeah. So a few things which Verma et al., the latest study, which was told in 189 cases, actually said that if you had a LTBP2, you needed a lensectomy rather than differentiating it clearly from the congenital glaucoma. What I'm trying to say from this case, which we have a long-term follow-up, is that since we knew the genetic diagnosis, I knew what to look for. That was one. We knew a confirmed diagnosis. And secondly, its representation like this has not been seen in literature, and we haven't found any glaucoma. We just have only 3 things: megalocornea, microspherophakia, and ectopia lentis, and we're still following it up. So maybe whether our case can expand the mutation spectrum and acts as a new reference for research on microspherophakia. Thank you.
Thank you, Dr. Monica. Excellent case, superb documentation, and a very apt title about the wandering lens. So, yeah. So, and good follow-up also. And that's why very good learning, because, it teaches that sometimes, as you mentioned, that the best treatment, that management is no management and just, observation.
Yes.
So that's very interesting. Why did it come anteriorly? I was
I
just
don't
thinking.
know. I don't know. And honestly speaking, when I like few people said that how can you say it's microspherophakia, because just looking at, because it's a larger cornea and a deep AC,
Uh,
that would it be microspherophakia, or would it be like, the lens might be normal, and just because it's a large
just
regular
fallen down.
cornea, yeah, it could be a normal lens. I don't know. I didn't measure it. Maybe next eye when it comes, I might measure it.
Yeah.
The other thing what I thought was that this was like this I mean, because I did the literature search, I made that table. The phenotype is a little different, and on what it has come and how it is presenting. The follow-up will of course tell whether this child develops glaucoma or doesn't, because primary congenital glaucoma also is done by it. I think the next speaker in fact would know more than me because she's on glaucoma.
Yeah. So I think it came entirely just to prove your point that it's actually
Yeah,
microspherophakic, so that
that's what I
everybody
thought.
could see it.
That's what I thought. That's what I was thinking. That is what it came as.
Yeah.
Just
So in LTBP2, what's the mechanism for the glaucoma?
so one is
Is
primary congenital glaucoma. The other one they said is because of microspherophakia, you have blockage, and the reason that goes and causes secondary glaucoma.
Yeah, so probably in your case, when it went down, behind or fell
Mm.
into the vitreous cavity, that secondary angle closure thing has, completely gone from it,
Yeah,
you know.
agree. Yes.
So that was completely eliminated, and probably that is why early glaucoma is not developed. And primary congenital glaucoma develops in those where there would be some element of a trabecular dysgenesis also, because LTBP2 is also responsible for
Exactly.
extracellular matrix.
Yes.
Maybe, the trabecular dysgenesis or some,
Yes. Yes.
I mean, I'm not very sure about
No, no,
how, but
it's
thinking,
expressed in the trabecular meshwork, and so it does
yes,
cause, and it is along with the other gene involved as well. It's not only independently that. So what happened is that the newer article which I read on 189 patients, which from LVP, Dr. Shirisha had they have presented it. So what they showed was that they had a phenotype, different phenotype, but all of them had glaucoma in their,
glaucoma, yeah.
yeah, even there the lenses have dislocated posteriorly.
Yes,
There,
even then they had
yeah,
glaucoma.
yeah, even then they had glaucoma. So all those
Yeah.
patients which they had of LTBP2, they all of them presented with glaucoma. So, and I mean, whatever the genetic table and all, what I read was that the whatever the exons which were affected did not
They were
include this
different.
exon. Yeah, exon 5 was
Yes,
not
yes.
there. So exon 5 was
Mm,
actually not been there in the literature. Exon
yeah.
5 on what happens and how it has represented. So I thought maybe this was a different thing where
Yes.
there's only megalocornea and it's not coming with glaucoma, and probably the child, I don't know, we'll have to follow up and see, because primary congenital coming now at this point would be rare. Secondary glaucoma also, if the lens pops in the AC and stays for a long time, probably, I don't know, because this lens
Mm,
popped out and I've operated him after 72 hours.
okay. But it's a very small lens, I feel. I mean,
Yeah, it
it
is a
was a
small
very small
lens.
lens,
That's
so
it looks
unlikely that
fun.
it'll cause a
Yeah,
pupillary block also if it's
yeah,
antigen.
yes.
Anyone else? Dr. Neelam, you want to add something?
Yeah, yeah. So we had
Yeah.
also similar case in which there was microspherophakia, but it was not so much megalocornea with LTB gene, and there was no glaucoma in that case. Another case we had like similar, but the like as usual, glaucoma was present, primary congenital glaucoma was present. Usually, like we see most of the cases, they will have primary congenital glaucoma, but we had also similar case. But the only thing was like they have reported so many variants.
Hmm.
So
Mm.
in one variant, LTB was there, like with microspherophakia and not megalocornea, only microspherophakia. But one learning point is whatever it is, whether it is primary congenital glaucoma or even if it is there is no glaucoma, better not to place any IOL.
Yes.
Yeah. Yeah, yeah, definitely. Even if the
Definitely.
lens size is appropriate, it's not microspherophakic. Still, there should not be any IOL placement in these eyes, especially in the bag or even, attached to the sclera or SFIL or something like that.
Yes.
So
Yeah,
for
because
for
we are in
these
very primitive
patients,
stage of all these genetic things, so we don't know like later whether patient is going to develop glaucoma. Like really, it is very difficult. So
And many, yeah, and many times they have high myopia also. So the aphakic
Yeah.
refraction is not that bad. I mean,
Yes.
they can actually wear glasses around 9, 10 diopters. So optical rehabilitation is not also not very difficult in them. So best to avoid the lens.
Yeah.
And yeah,
So even in
any
our
chance,
case,
yeah,
our case,
go
it was
go
a
ahead.
high myop with now he's using just +2 for distance and +3 for,
Yeah,
so he's doing very well on that account.
yeah, and very high risk for myopic degenerations
Yes.
also. So need
Yes.
to watch out for glaucoma as well as retinal
Retinal.
degenerations like lattice in
Yes.
them and RD. Any chance of doing a gonioscopy for this child?
Hmm. I
Not yet.
I haven't still.
Yeah, yeah, yeah.
But I
Yeah,
can do
maybe
that and
you
see
can
how
do
the
it
angles
and
are
see
and
how the angles are
yeah,
to.
how the angles
Uh,
are and how he is otherwise. Yeah. I think I can do that and see. Yes.
yeah. Anyone else from the audience has a question? Nivita, are there any in the chat box?
No, ma'am.
Okay. Then maybe we can move on to the next case then.
Yeah.
Nivedita, is it visible in full slide?
Yes, Dr. Neelam.
Yeah. So thank you, Dr. Shalja, Nivedita, and all the other people who have joined today evening 7 to 8 for genetic club presentation. So I will be presenting something differently which from our routine, and usually we don't look, I don't know, like we don't usually look for all these genes in craniosynostosis. So topic is TWIST1 and FGFR2 in syndromic craniosynostosis. So I'm Pediatric Ophthalmology and Strabismus consultant at Aravind Eye Hospital, Tirunelveli. So before going to case presentation, just I will describe because all of us, like we always get confused, what are the sutures in craniosynostosis. I will just give a brief description. So craniosynostosis, as all of us we know, that it is a highly clinically and genetically heterogeneous group of congenital craniofacial malformation due to the premature ossification of cranial suture, and every suture is having a different timeline during which they fuse. So premature suture fusion occurring in craniosynostosis leads to a skull growth, and it is actually perpendicular to the closed suture, like perpendicular to the direction of the lower resistance, perpendicular to the patent suture, which is known as Virchow's law. So craniosynostosis, if we see the incidence, it occurs in 1 to 2000 to 2500 live birth, and it is second most common prevalent craniofacial defect. And if we see worldwidely, nearly 85,000 children are diagnosed with craniosynostosis in a year. So a combination of environmental and genetic factors are responsible for this. And if we see, this is the coronal suture, and therefore, because it is in two sides, so we can have like two presentation, either a unilateral coronal craniosynostosis, and if both are fused, then we call it as a bicoronal craniosynostosis. And this one is sagittal suture, and this is lamboid suture, which is like rarely seen, least reported. And this front one is the metopic suture. So first three top pictures are of a newborn with premature closure, like in 6-month-old child with premature fusion of the right coronal suture, this in 6-month-old, and D2, all this down one are premature closure of sagittal suture. So if you see, if this suture is closed here, so skull has grown perpendicular to the open suture. And here, this one is the closed suture. So again, skull has grown perpendicular to the open suture. So this is known as Virchow's law. So there's another classification according to which if one suture, usually with one suture, we see the non-syndromic craniosynostosis, and with multiple suture, we see the syndromic craniosynostosis. And in secondary cases, sometimes with storage disorder, metabolic disorders, we can have secondary craniosynostosis also. So non-syndromic craniosynostosis, they occur as an isolated phenotypic trait, while syndromic craniosynostosis, they represent a feature where complex syndrome is associated with extracranial defect. And non-syndromic craniosynostosis are actually more common. We see a lot of cases, and around 70% of all craniosynostosis come under this category. And then they can be classified according to the suture site, sagittal, metopic, uni or bicoronal, or uni or bilamboid suture, because these are two sutures. So they can have this type of presentation and resulting in the skull dysmorphism. While in syndromic form, only 25 to 30% of craniosynostosis can have some syndromes. And along with premature fusion, we can have additional variable inborn defects or developmental delay. And if we see in the OMIM database, more than 150 Mendelian disorders have been reported with craniosynostosis. So if we go into this site, we will see like so many syndromes, and along with that, non-syndromic genes, they have been reported in craniosynostosis. So either there is a single gene mutation or chromosomal structural abnormalities in 80% of syndromic cases we can see. So if in our OMIM database, if we put the term craniosynostosis and we see the clinical synopsis history, we can see that 195, it shows 195 clinical synopsis. So 195 clinical genes have been reported in craniosynostosis. So I will not go into details, but we'll see what genes are responsible in these. So these are mainly the genes which are responsible for interconnected signaling cascade, which are mainly involved in the skeletal and craniofacial development. So 7 genes are mainly responsible in these signal molecules, namely fibroblast growth factor receptor 1, 2, and 3, and then twist family transcription factor, that is TWIST1 gene, muscle segment homobox MSX2 gene, and ephrin B1 and transcription factor 12. So these are the commonly reported. Otherwise, we are having like so many genes. So in autosomal dominant pattern of inheritance, usually there is a gain of function with this FGFR2 to 3 and with MXX2 mutation, while there is loss of function or dominant negative function in TWIST1 and EFNBVN and TCF12 mutation. So usually this total loss of function is not reported, because otherwise it is like complete loss is lethal in utero itself. So it is not so commonly reported. More commonly reported is gain of function and haploinsufficiency. And gain of this function missense mutation we can see in FGFR1 to 2, 3. And this FGFR2 is predominantly expressed in all this whatever cells which are responsible for cranial vault formation, and every gene has an individual role. So whenever we see a craniosynostosis case, if suture is affected, like if there is no additional malformation or developmental delay, only the sutural like suture only is closed, then we can have all these different forms, and then we can go for direct gene sequencing. And if it is negative, then we can go for targeted next generation sequencing. If we know the syndrome, then we can go for direct gene sequencing. And if the test is negative, then we can go for whole exome or whole genome sequencing. So this is usually like, this is followed by the neurosurgeon people. Unfortunately, like they don't include in clinical evaluation ophthalmologist. And actually ophthalmologist should be a part of this clinical evaluation also. So in India, we are not having any craniosynostosis next generation sequencing panel. If there is a panel, it looks for all the genes which comprises of these common craniosynostosis syndrome, like Eppert, Cruzon, C3-Shozen, and all this syndrome. And without this syndrome also, we can get all these genes. So we can have chromosomal microanalysis or microarray analysis or whole exome or whole genome sequencing. So before 3-4 years, we published so many papers on craniosynostosis, but we we never thought of like looking genes in these cases. So I thought at least we will have some discussion for the genes in this craniosynostosis. So Cruzon, as we see, it is typical features of proptosis, frontal bossing, a sharp nose. While in C3 syndrome, there is a supraorbital retrusion with shallow orbit and sharp beak-shaped nose, and facial asymmetry and ptosis. Ptosis we don't get routinely in Cruzon, we mainly get proptosis. So first case is of a 2-year-old male with heterozygous TWIST1 exon mutation with bifrontal craniosynostosis, bilateral ptosis, and a large alternating exotropia. And he presented to us with a severe ptosis at 1 year of age, and that time he was fixing and following light and a large alternating exotropia. We referred this patient to higher neurosurgery center, where patient went last year. He went cranial vault advancement and frontal bone remodeling. And after the surgery, the ptosis was like drastically, I'm not having the pre-op picture, but after surgery, a patient ptosis from severe, it became moderate. And even the exotropia, like it was slightly less. Right now, previously it was constant large angle. Right now it is like alternating exotropia. Sometime angle is less, like he has started fixing with both eyes. And he's having astigmatism in both eye. Fundus is within normal limit, and MRI shows asymmetrical ventricular dilatation and mild thinning of extraocular muscles. And in CT also, there are features which are suggestive of a craniofacial surgery. So this is the photo of this Cederer-Chosen syndrome. What I learned from the neurosurgeon people, that really they give very nice OMMI number and they attach this OMMI number along with all the phenotypic features of that syndrome, and then they usually tick what are the features they got in this patient. So for this particular boy, they ticked flat face, flat forehead, plagiocephaly, strabismus, ptosis, S-shaped blepharotosis. So it is a very nice, and even they have documented the height also. Like at 9 months, patient was 67 centimeter. At 1 year, it became 73 centimeter. So once you put, I have not included all the images because right now this paper is under publication. So I have not included all the images. So if we put in MMI, OMMI, this number 1014, and usually in 1000 series, we will have all autosomal conditions. So when we put this Cederer-Chosen syndrome, we will get two phenotypes. One is with or without eyelid anomalies, just like our patient. And then there is another without any eyelid anomalies. So whenever eyelid anomalies are there, usually it is associated with TWIST1 and inheritance, it's autosomal dominant. And another form is also there in which chromosome 10 is involved. In that, FGFR2 is involved. So if we come to the genetic report of this patient, this was at 1 year. He was born of a second-degree consanguineous marriage. And if we see gene responsible is TWIST1, location it as exon 1. This is the variant with the heterozygous zygosity. And this is Cederer-Chosen syndrome with or without eyelid anomalies with this OMMI number, and craniosynostosis 1, which also this neurosurgery people, they have given. And inheritance is autosomal dominant, and this is the likely pathogenic. And if we see the variant description, a heterozygous nonsense variant in exon 1 of the TWIST1 gene, which result in a stop codon and premature truncation. As I told earlier, that here most of the loss function will happen. It happens like it is associated with TWIST1. So that result in stop codon and premature truncation of the protein at codon 3 was detected. So this I have already described, the TWIST1 gene located on chromosomal 7521, and this gene encodes a class 2 basic helix loop helix transcription factors, which play a critical role in regulation of embryonic development, particularly in craniofacial and limb morphogenesis. And it not only affect the muscle, facial muscle, bone and connective tissue of the craniofacial region, but it also affect the extraocular muscle. We will see next slide. and it is also responsible for the neural tube formation. And beside this syndrome, it can also be seen in some cases of isolated craniosynostosis, like in non-syndromic also we can have this gene. So usually with syndromic craniosynostosis, we see a large V pattern strabismus, more commonly exotropia and less commonly esotropia. And several mechanisms have been proposed that because of abnormal orbital morphology, it can be there, mispositioning of the extraocular muscle and absence of extraocular muscle. So interestingly, in some patient also we can get like isolated ptosis without the craniosynostosis, and then also patient will have a TWIST1 mutation. So which raises the possibility that TWIST1 plays a direct role in extraocular muscle and levator muscle development. So though ptosis is a well-documented feature in this TWIST1 related craniosynostosis, extraocular muscle, whether it is involved or not involved in humans, it is not so widely studied, while we are having so many animal reports. In animal, like detailed study has been done in mice, in which they show that this TWIST1 gene is responsible for the extraocular muscle hypoplasia also. So many tendon, like tendon is also not so good. So strabismus in animals can be because of abnormal development of the extraocular muscle, resulting abnormalities in tendon formation and innervation. And TWIST1 deficient mice, they exhibited disrupted myogenesis and extraocular muscle hypoplasia. So in our case, we had TWIST1 mutation and extraocular muscle hypoplasia. It was like very mild thinning of muscle. We were not able to get the exact measurement of the muscle, but very mild thinning of muscle was reported. So this case highlights that besides ptosis and besides exotropia, there is evidence that these patients can have thinning of the extraocular muscle. And whenever we are doing surgery, like we can, in some cases, we can make out that the muscles are very thin, and the surgical dosage, whatever we are applying, it will not be adequate for that particular patient with the abnormal skull. So maybe the hypothesis is that TWIST1 could be responsible for those cases and for undercorrection of strabismus and responsible for the thinning of muscle. So there are various case reports by various authors on this TWIST1 mutation, but most of them, they report about craniofacial and limb deformities. There is a meta-analysis which tells about all the details of all these syndromes. And if we see this C3-Shozen syndrome, most of the cases they are having exotropia and astigmatism. Here also, most of the cases like esotropia 29 and 24. So most of the cases, they report both esotropia and exotropia, and some cases they have reported hypertropia also. So conclusion is that this case provides a new evidence suggesting that TWIST1 involvement in human extraocular muscle development, and in animal models it is nicely mentioned. In human it is not so, everybody is reporting exotropia or esotropia, but muscle thinning nobody has reported. And further research is needed to investigate the role of ocular motility disorder associated with craniosynostosis syndrome. Then moving to second case, there's nothing new in this case, but just to highlight that how the FGFR2 cases can be different. It is just a hypothesis. When we operate, then only we'll come to know how the muscles are, whether they correlate with the TWIST1 gene or not. So in this particular patient, this patient is coming to us right now. She's 9 years and she's coming to us since age of 1 year. She has undergone various craniofacial surgeries, but previously because genetic tests were not available, so genetic test was not done, and in 2023 only genetic test was done. And here after Sanger validation, FGFR2 in exon 7 was reported in heterozygous form. So heterozygous missense variant in exon 7 of the FGFR2 gene in chromosome 10 was detected. And this patient also had exotropia, but here the exotropia was because patient in her early childhood, she developed papilledema She went late for surgery, so she lost vision in one eye. One eye is hand movement and other eye is 6/18. Though both eye they are having right eye is total optic atrophy. Left eye is also optic atrophy, but she is still having like central vision. So the purpose of presenting these two variants is that in one variant we should always look for the muscle thinning. In other variant we should always look for the papilledema and all other things. They can be secondary responsible for the strabismus. And with all the craniosynostosis, non-syndromic craniosynostosis also, if we are doing the gene analysis, then we can get so many new result. Unfortunately, in India, we are not having any craniosynostosis panel. So whatever like genetic clinic reports give us, we have to rely on this. So this was about that girl. She has undergone various surgery and twice she had subluxation of the globe because of the shallow orbit and proptosis. 2 times she came into emergency department with her eye hanging outside. So the take-home message with these two cases are that whenever we see craniosynostosis, we have to look beyond so many things in craniosynostosis. Thank you. Hope so. It will be useful for everybody. And if anybody is having experiences with this genes, they can share their experience.
Again, excellent cases, Dr. Pawar. Thank you for sharing with us. Your initial explanation about the craniosynostosis and the various mechanisms, how it closes and how it forms, was again very informative. And I'm thinking must have been very useful for everybody.
Yeah,
So,
I think, and in PSM, somebody asked whether for genetic thing. With Hannah, somebody asked, like, she got in 2 cases, very thinning of muscle in craniosynostosis. So what to do for genetic test? So I discussed with Hannah also, but she was like that, they are having that gene panel, craniosynostosis. So for them, it is very like easy. They are having proper protocol. For them, it is not a problem.
mm. So the message is both ways actually. For craniosynostosis, you should look beyond it and see how it is affecting the eyes and the muscles. At the same time, when you look at strabismus with something an odd-looking face or a head, you should always look for craniosynostosis. Sometimes, as you mentioned, isolated craniosynostosis is quite subtle, and things like
Yeah.
plagiocephaly can be missed,
Yeah.
and which have direct implications on the strabismus evaluation.
Yeah.
So, thinning of the muscles per se, I haven't encountered. I would admit that I haven't encountered any case where I have myself done a genetic testing in a craniosynostosis. Most of the time, it's a clinical diagnosis, like whether it's a Crouzon's or a FIFR or a other syndromes. And the strabismus, usually what we see is like a large V patterns or patterns and large angle strabismus. And of course, the element of papilledema or optic atrophy is also there in them because of either raised ICT or thin optic canal or a narrow optic canal where there can be compression. So these are the things which I have seen per se, and the few cases where I've operated in craniosynostosis, I mean, during surgery, at least I have not felt that the muscles are thin. Maybe this mild thin. So, did you operate on the first case?
No, still it is pending. It is 2 year. A neurosurgeon, they have said like it is still under observation whether to plan for another surgery or not. Like they have asked us right now not to operate, like observe for few months because child is right now just 2 years old. So, and surgery was done last month. So they just want like some observation period. And after that, like we have counseled patient that then we'll go for surgery.
Yeah, so it would be interesting to know.
Yeah.
Yeah, whether clinically, I mean, while you're doing surgery, you can actually see that the muscles are thin, because in the MRI also there was just mildly thin, right?
Yeah. And even sometimes when they are not so thin, the tendon organization, we don't know how the muscle is acting. So that under correction after surgery, like doing large, we have seen in 2-3 cases of non-syndromic craniosynostosis, like in a child doing 14/6 in both eye, still having a large residual exotropia. So maybe the muscles are not like, we cannot make out, but structurally their sacrolemma, everything, like really we don't know. Histologically, we don't know how the muscle is.
Yeah. There are two people in questions in the chat box. Nivedita, would you like to take them, or you can ask people to unmute
Yes,
them then ask? Yeah.
I'll go ahead and ask.
Mhm.
Raman is saying that muscles were thinning in his case in which he operated, Dr. Raman. And Ria has asked if the two cases had any family history of the disease because Sanger was done in one of them, I think you mentioned.
Yeah, second case, Sanger, they have done. But there's no family history.
Directly Sanger, ma'am. How did they get which
No,
variant to be done?
The
no, they,
parent testing was done, but none of the
In the
no, it was mentioned that the variant has been found in NGS, and then I think confirmation by
then confirmed with Sanger's.
okay.
It's a Sanger confirmation report which has been shared.
Shit, yeah.
But NGS was done before it.
It was
As
done
The
before.
index
the
case.
report, yeah, when I saw it. Yeah.
Okay.
Like mother is also having very large face, big eyes, but not typical. Only that mild dysmorphism, very minimal dysmorphism.
Mhm.
Are there any
And
other questions?
yeah. And people can directly unmute and ask. It's an open forum,
I
unless
also wanted to say that the presentation was like extremely educational and very nice. There was a lot of information, like compactly, we learned a lot in this time. Thank you, ma'am.
so. If we, Dr. Neelam is there, yeah.
Yeah.
What would be like the clinical implication of knowing this? I mean, just for the interest of the people who are attending. Some of them may not be strabismus specialists. So if you know whether it's a twist versus an FGFR, or where you expect a thinning versus not expecting a thinning.
Yeah,
Just
see, like, it is very difficult. Like right now, that's what I'm saying. Right now, only we are getting, and these are not all the tests which we are advising. Whatever we are getting, it is from a neurosurgeon, neurosurgery department, other hospital. So we cannot like reach to this was just a single isolated case report and a correlation with the animal model. Maybe in future when we'll get more cases like more documentation, then only we can reach to some conclusion.
yeah, and maybe predict more better that where you would expect to get thinning of muscles, and the strabismus surgery may not be that effective, or you need to increase your dosage in them so that you get
Yeah, yeah.
a
So many times, like non-syndromic children, they come with so much variation. They will have some hair we will never notice, and our surgical dosage is not working. Then patient will not come for follow-up. We will also not bother. They will also not bother. Like so many things are their child growing with growing child. Sometimes they will also take us. They will also not come to doctors on regular follow-up. So it is.
yeah. So it's
Hello.
important to keep gaining knowledge. Hi, Tanmay.
Hi. So I wanted to ask one question to Shelja also and Dr. Neelam ma'am also. Other than thinning, I think we also expect alteration of muscle pathways in craniosynostosis.
Yeah, yeah.
So we do an MRI to look out for the extraocular muscles in all cases.
Right.
MRI would be done for probably the CT is done for the craniosynostosis. But do we do an MRI in each case before operating just to know the muscle paths of the extraocular muscles?
Like for all craniosynostosis, all
Yes,
syndrome.
if we are going to operate, if there's a
Yeah.
strabismus associated in a case of craniosynostosis and we want to operate, and sometimes there is a pseudo inferior oblique overaction, which is probably due to an altered muscle pathway. So is it recommended? Do you think it's a good idea to get a MRI done before these surgeries so that we
Yeah,
don't?
yeah, actually it is good. Like in pachycephaly and all things, like it is always better. But that is what I'm saying. So many times in non-syndromic, we also miss. We don't know like child height, circumference, where we are seeing subtle things we will be missing.
Yeah. So posterior plagiocephaly is quite common if you see, and
Yeah,
it's completely covered by the hair. And it's an
yeah.
isolated craniosynostosis. Anterior one are the ones which will be associated with strabismus, and mostly it would be the esopulsi.
Yeah.
also because of the abnormal location of the trochlea, which would be like a desensitization. So definitely, I would say that in all craniosynostosis, imaging should be done. It not only helps in assessing whether muscles are thin, sometimes they can be absent, sometimes then the parts could be altered. So it's a good practice also to guide yourself like what surgery to be done. For example, if you really see the rotation of the globe, then you might be thinking of the rotation of the muscles in the globe. Then you
Yeah.
might think of shifting the muscles rather than operating on the obliques. So, especially if there is a V or an A, I would definitely go ahead. If I'm not finding a V or A, or it's a very simple strabismus like a exo or ESO, I have sometimes not done a MRI and just operated because there,
Yeah.
even if it is there, my surgical plan would not change.
Change. Yeah.
Yeah. And a couple of times when there is a clear-cut anterior plagiocephaly, which is not syndromic, and it fits into that typical SO palsy. So there also I may not image, just for the sake of, the surgical planning. But if, of
Yeah.
course, other syndromic things, if anything else, I'm suspecting if there are any neurological issues, then along with the MRI brain, then in orbit, both.
And as you said, posterior plagiocephaly is really missed because it is a common thing. We always see how patient is entering, how his gaze, how his facial features. We usually never look how their backside is. Like we never look. By that time, we will be writing something or entering something into EMR. So that is also, I think, like it is missed so many times, the posterior deformational plagiocephaly.
Yeah. So no further questions or comments from my side. If anybody else has any questions or comments to make from the audience, if none, then I would like to thank both the presenters today. Again, two very interesting cases and quite different cases, and very well managed, both of them. Thank you, Dr. Neelam and Dr. Monica, for presenting today.